Hello, Pulmonary. Again, this is chapter 2. Some questions about ARDS, the benefits and the risks, and how to avoid further deterioration, decrease mortality, improving the outcome with patient on ventilators suspected with ARDS is to keep the PEEP high from 10 to 15 with your target goal is the plateau pressure less than 30. Use the minimum of tidal volume, 4 to 6 per kg, 4 to 6 mil. Permissive hypercapnia is unacceptable as much as the pH is not less than 7.2. Conservative use of IV fluid. Remember that equation of the pressure is equal and proportional to the resistance to minute ventilation tidal volume, and it's inverse related to the compliance. Means the more, if you see in that mechanical ventilator there is an alarm about high pressure, plateau pressure is very high, more than 30, then you have to suspect the resistance or the flow is high because of the patient compressed or pecked on the AT tube, or there is a mucus plug, or even bronchospasm, patient has COPD and asthma, severe exacerbation. There's a questions about ventilator-associated pneumonia, how decrease risk with oral hygiene, anti-aspiration positions, avoiding the use of PPI and H blockers, critical care myopathy and paralysis and weakness after an ICU admission, prolonged hospitalization in the ICU. Critical care myopathy associated with mild to normally elevated CK with normal or flaccid paralysis in physical exam. Um Increased risk by use of neuromuscular and steroid. Rhabdomyolysis, there is very high CK and the patient severe muscle pain. Prolonged neuromuscular agent use related paralysis, there is a use of neuromuscular for more than days, and the patient has a transient kind of paralysis and weakness that responds very well for anticholine, cholinergic or anti-acetylcholine esterase. Normal CK. Lung abscess is one of the questions. If your patients will start with to have like indolent, slow onset pneumonia with an X-ray, there is air fluid level. Treatment use of augmentin or meropenem, carbapenems. Try to avoid clindamycin as that will increase the risk of C. diff. The questions about kyphoscoliosis and how to treat their chronic respiratory failure. It's the use of non-invasive ventilation with a positive pressure. A question about Trali. Maybe they ask you about the physiology, how this happened after the blood transfusion, transient pulmonary edema, usually due to donor's antibody against the patient's white disease. Other questions also will be about extubation. If the patient says there is a test you can do before extubating the patient, which is the rapid shallow breathing test, means the respiratory rate over the tidal volume. If it's less than 105, it's a good indicator. If the patient awake, if the patient have a strong cough, if the patient follow commands, there is a few secretions. And most important, that the primary indication for mechanical ventilator is already resolved. The primary treatment the primary problem resolved, there is no the pneumonia improved, or the patient, if he came with atelectasis or whatever is the case, sepsis, we treated the sepsis, then it's a good indicator for extubation. The risk factor for extubation failure is wake cough, frequent secretions, altered mental status, positive fluid balance. If the primary problem was pneumonia, if the patient already age above 65, there's multiple comorbidities, there is a chance of extubation failure if it's prolonged or lasts more than 14 days. Other options like tracheostomy should be tried. If the patient just extubated and start to have some respiratory distress, respiratory failure, hypoxia, saturations drop below 90 with still using an FiO2 of more 50%, respiratory rate more than 25, pH keep dropping, going for acidosis, CO2 increasing, 145. Signs of respiratory failure: gasping, intercostal muscle retractions, accessory muscle use, abdominal breathing, paradoxical abdominal movement. Then your patient is failing and pending respiratory failure. You have to re-intubate him. The only patient that you may delay the intubation and use non-invasive ventilation, in this case is the COPD patient, you can use to try the BiPAP for maybe 1 to 2 hours, repeat the APGs, reevaluate. If they improve, that's excellent. If not, they need re-intubation. How to decrease the duration of mechanical ventilator? It's the best protocol is the protocol sedation break. You give them a break with a sedation and reassess for mental status. And this question will be different than how to decrease mortality in ARDS. The question about the duration, decrease the duration on a mechanical ventilator. An example of this may have a patient that has been intubated for several days, and after extubation, he failed to mobilize after the extubation. Next, you have to test his CK. If it's normal, you think about ICU acquired weakness. Capnogram, that device, when it's attached to the patient ET tube during CPR, it can replace the few seconds of stop and check pulse. So you don't have to check the pulse as much as the capnogram is already connected there. Because if RASC achieved and there is return of circulation, you will see a sudden rise on the capnogram. That's still telling you that the circulation is back, and now tissue releasing CO2 and goes to the lung and it's exhaled in the lung. So there is a return of circulation. Non-invasive ventilation can help also on cardiogenic edema because it can decrease preload, decrease afterload, and that will improve the circulation. Also can improve oxygenation by decrease the dead space, by increasing the tidal volume, by increasing the alveolar ventilation. So it's a good option for pulmonary edema and cardiogenic edema. ICU when there is no contraindication, of course. Uh, Feeding in the ICU, there is at least one question or two questions about feeding, when to start feeding and when to reach the target. You have usually to start the feeding within 24 to 48 hours. If hemodynamically is stable, you don't want to start with the patient hemodynamically unstable and the patient later on goes for cardiac arrest and they start CPR and then the gastric continental reflux and go for aspiration pneumonia. But ideally 24 to 48 hours start feeding and reach the target within 2 to 3 days. Enteral is more preferred, of course, than parenteral, and gastric or oral more than jejunal. Target blood sugar would be 140 to 180 is enough in the ICU, and if you need to use insulin, use short acting as their blood sugar will be fluctuating in the ICU. It will be variable. For chronic thromboembolic disease, for the diagnosis, you use VQ scan if the chest X-ray clear and there is no signs of structural lung disease. Would be good to start with and good for diagnosis. Uh, loop Check loops and see all type of loops. You can just type on the Google and see which one is fixed inspiratory, which one is for obstructive lung disease, which is for restrictive lungs. Just looking to the loop because you may have this on the test and that will save you time. One of the causes for fixed airway obstruction means it's flat in the inspiratory and expiratory phase. That's an external compression like a goiter or a mass. Pulmonary arterial hypertension is common in the test. If you test a patient with a pulmonary hypertension with a pulmonary function test, you are expected the pulmonary function test to be normal, except in the DLCO will be low. If a patient with a lung disease, for example, a COPD, and you find that he has a pulmonary hypertension and COPD should be mild to moderate, but should not be severe. If it's severe, then you have to find and to rule out another severe structural lung disease. Patient with asplenic, there is no spleen, splenectomy, they are increased risk for encapsulated organisms like pneumococcus, Haemophilus influenza, and Neisseria. If there is any signs of infection, fever, they are may quickly and rapidly deteriorated, so you have to start the antibiotics, ideally in the hospital with IV. Uh, Nasal polyposis, asthma, aspirin, and NSAIDs used. This is the nasal polyp syndrome, aspirin nasal polyp syndrome. It's not an IgE mediated, it's a leukotrienes mediated, and they respond very well for leukotrienes antagonist. Again, also you need to optimize the asthma, avoid NSAIDs, avoid aspirin. If aspirin indicated and there is no alternative, you need to do aspirin desensitization. Pulmonary impulse, you start with if the patient hemodynamically is stable or unstable. If the patient hemodynamically unstable, Then next you need to do a bedside echo and to look for the signs of RV straining. If there is signs of RV straining, ballooning, RV failure, then the next is thrombectomy, either interventional or TPA, but you have to deal with the thrombus. And a hemodynamical stable, you need to confirm that with a CTPE. Pleural effusion is very common in the test. They may ask you about the diagnosis, the causes, the indication for dracocentesis, or the indication for chest tube. Indication for chest tube for high risk effusion, high risk for infection. pH less than 7.2, glucose less than 60, exudate, gram state is positive. It's better to have a chest tube. Low risk patients, loculated, half hemothorax or more than a half pneumothorax, pleural thickening, then you may need a diagnostic thoracentesis before going and draining that tube just for the diagnosis. It could be a malignancy, it could be a more advanced that you need later on a biopsy. So diagnostic thoracentesis is more than going for its as it's less likely to be infection, especially if it's a transudate. You can use light criteria to differentiate transudate from exudate, which is pleural protein to the serum protein more than 0.5, LDH more than 0.6, or if it's less, that's a transudate. You can use, if the patient already taken diuretics, then you have to use SAG, serum protein minus pleural protein, or serum albumin minus pleural albumin, and that will tell you the transudate versus exudate. If the pleural fluid already showed severe, very low glucose, less than 30, that's very high likely due to rheumatoid arthritis. If the pleural fluid showed looks white and there is a chylus or pseudochylus, means the lipid is high, the triglyceride is high, that's very likely is a rheumatoid arthritis. The other reasons for very high, very elevated triglyceride is thoracic duct injury, tumor that producing triglyceride in the chest, pneumothorax also, especially a young man comes to the hospital, sudden chest pain. If you look to the x-ray, clinically the patient is stable, then you have to admit the patient, put him on nasal oxygen till and observe this pneumothorax to improve or seal. For the diagnosis, young, it depends. If they tell you like he has a marfanoid features, you can start thinking about marfanoid and other differential diagnosis. You look to the echo and you see if there is an aortic insufficiency or bicuspid valve. Um, if a patient is a young non-smoker with comes with a pneumothorax and chest CT looks emphysematous, you start thinking about bronchial alveolitis or bronchiolitis, interstitial lung disease. If she's a female with signs of interstitial lung disease and CT receives cystic lesions, thin wall, you start thinking about LAM, leiomyomatosis, especially non-smokers. Uh, Again, treatment of pulmonary hypertension, if it's due to chronic thromboembolic disease, the treatment should be warfarin. Cyanosis. A patient comes with a cyanosis, and the blood analysis, they may tell you it looks like chocolate or it's very dark. Patient PO2 looks normal, but the saturation is very low. Again, this is an indication this is methemoglobinemia, and the treatment will be methylene blue. Bronchiectasis, and first thing to do if you check the patients and you think there is a bronchiectasis in the CT or a chest X-ray, first to check is pulmonary function test that diagnose the bronchiectasis or give you signs of obstructive disease in pulmonary function test. But most important, especially in a young patients, you need to do IG levels and check the sputum culture for to guide you for treatment. Good Pasteur disease, we will talk about those pulmonary syndrome in the rheumatology section, but good Pasteur disease, different from granulomatous polyangiitis by it has no cavitary lesions on CT scan, just X-ray, unlikely to have upper respiratory sinusitis, runny nose, and ENT problems, eye problems, skin problems, as granulomatous polyangiitis. Post-radiation pneumonitis, it's a late reaction that's happened or started after 4 to 12 weeks that needs in the treatment a high dose of steroid, and that's tapered slowly after 2 weeks, up to 3 to 12 weeks of tapering. Obstructive sleep apnea and apnea-hypopnea syndrome and obesity hypoventilation syndrome, those are common in the test. The diagnosis, the treatment, understand the symptoms, the signs, nocturnal problems, arrhythmias, complications, untreated hypertension, very high pulmonary hypertension. Then you need to suspect obstructive sleep apnea. You can start with stop bang for screening. For hypoventilation syndrome, you start with obesity or the PMI that more than 30. Then you go for APGs and you find high CO2 and PO2, the low oxygenation less than 70. Then this is obesity hyperventilation syndrome. Treatment for post CPAP, either for obstructive sleep apnea or obesity hyperventilation syndrome. Narcolepsy is different as the patient has a daytime sleeping, daytime sleep paralysis. They have decreased CSF hypocreatine. You don't need to test for that. Diagnosis with multi sleep latency and the treatment with a stimulant as modafinil. REM behavioral disorder, another sleep problem that you have a question on the test. They are away. They have the behavioral disorder. They have more fighting during the sleep, more aggressive during their sleep, and when they awake, they look more confused. Uh, those kind of behavioral disorder with REM sleep may associated or increase risks of Parkinson disease and neurodegenerative disorder, Lewy dementia. This is where the question will be around about the association problems. Differential diagnosis again from the sleeping or the sleepwalking. There is no fight. The patient is not aggressive, and the patient, once he awake, will be confused. A question about a lip swelling after the use of ACE inhibitor. The treatment against stop ACE. You can test for C1 esterase level or C3 if the patient has a congenital disease with the deficiency of the enzyme. That means they're not going to respond for epinephrine steroid. You have to replace this. Then you may have a question about acetaminophen toxicity. Either they will ask you about the treatment, the use of NAC, testing for the level, or they may ask you about, we already started him on NAC, they already the patient know it's a Tylenol, we are following his level, what next? You have also to give them activated charcoal for all poisons and intoxication to decrease the GI reabsorption of the toxins. There is maybe a question about, it's a common question about milk alcohol syndrome. You can suspect milk alcohol syndrome if the patient has metabolic alkalosis, maybe hypercalcemia and renal insufficiency. Usually the patient's medication will have some tummies or calcium carbonate, so that's what may give them the alkalosis. Treatment is normal saline IV infusion fluid, but if it's very severe, you can also use furosemide or Lasix to decrease to increase the excretion of calcium. Thank you very much and good luck.